brief introduction, but first I want to let everybody know that we are recording, as you just heard, for later viewing. If you, as Dr. Hunt is giving her lecture, if you need any clarifying questions answered about the data being presented, feel free to enter those into the Q&A box, which is a button down at the bottom, and we'll try to answer those as we go. Otherwise, we will stop the recording at the end of the formal presentation, and we will open it up to questions and dialogue. Some of the topics that Dr. Hunt's going to talk about can be a little sensitive, and we want to make sure we're stopping the recording to make sure people feel free that they can be free in their questions, and we can give honest answers. So with that, it is my pleasure to introduce Dr. Tamerah Hunt. She is a Michigan native from Flint. She received her bachelor's degree from the University of Delaware, master's degree from James Madison University, and then her doctorate degree from the University of Georgia in 2006. From there, she went on and took her first faculty position at the University of South Carolina, was there briefly, but then later moved to the Ohio State University, that school down south, as we like to say here. And then was there for about 7 years and then returned to Georgia and is now on faculty at Georgia Southern University. At Georgia Southern, she is an associate professor of athletic training and the graduate program coordinator for the athletic training program. She has extensive clinical experience as an athletic trainer with specific interests in high school athletes and underserved populations. As a researcher, she's focused on youth concussion assessments and the effect of socioeconomic status on incidence, management, and recovery outcomes, as well as other comorbidities that influence adolescent recovery patterns. I have known Tamerah, we actually went to school together at Georgia, so I've known Tamerah for nearly 20 years, so it is my pleasure to introduce her not only as a colleague, but as a friend to our inaugural quarterly lecture series. Please join me in welcoming Dr. Tamerah Hunt.
Thank you. Wow, Steve, first of all, thanks for making me feel old, but that's okay. 20 years, wow. So I want to start by saying thank you so much for inviting me. I appreciate this. Again, technology is my friend. I have to keep telling that to myself. So this should be working. Yes, excellent. Okay. So first, thank you so much. Thank you for joining us. Again, if you have questions, please feel free to stop me. I am from Michigan. I am now living in Georgia, and my students always yell and laugh at me because I talk so quickly. So I am glad this is being recorded so you can go back to it later, because as I start talking and getting excited, I will talk even quicker. But my goal is to give you some background information, talk about some studies that we've done, and then give you some clinical pearls of wisdom, and then ending with a nice question and answer session. So please feel free. This is a great time for us to have these discussions. We are in a very new and different situation. Tension is high, and the only way we're going to get over it is to talk about it. So I am going to talk about SES and racial disparities. Dr. Broglio emailed me. He was like, hey, can you talk about racial disparities? And I'm like, I don't necessarily do research in racial disparities, but I am going to talk about it. So here we go. So hopefully by the end of this session, you will, yes, I'm a teacher, so this is going to happen. But hopefully by the end of this session, we're going to talk about some of the social determinants of health. We're also going to talk about the ramification of low SES in race on concussion assessment, specifically neuropsych testing, because that's probably our most common area where we're going to see differences in race and SES. And then hopefully I'm going to leave you with some successful management strategies to enhance the recovery through positive social support, and then some specific pearls of wisdom that hopefully will help get your thoughts going. So to start, social determinants of health. These really are factors. This is a public health model, and it's coming from this economic and social conditions that influence individual and group differences in health status. The biggest issue with this, though, is that it is an intersection of a lot of factors. Some of the more common factors we're going to see are going to be environment, they're going to be biological, there's going to be social, but a lot of times what we see happening is specifically race and ethnicity and SES. We know that there's strong evidence that race and ethnicity are going to impact outcomes for patients, especially those in the minority having poor health status. We talk about, you know, again, I'm growing up in this community and I remember my grandparents and I remember my aunts and uncles talking about they got the sugars, right? So we know that minorities have a significant disproportional incidence of diabetes and obesity and high blood pressure. We also know, though, that that's limited by the access to medical care that they may have, especially when you start looking in some of the rural areas or some of the inner city areas where they just don't have access to those healthcare providers, or there's a cultural mistrust where they might actually say, I'm not going to go to the doctor because I knew somebody that went to the doctor and they didn't come home. So those are going to be those issues that we're going to want to talk about. However, I want to make it very clear, there are limited studies that examine race in isolation, and there's probably a multitude of factors for that. Honestly, the biggest factor is race as a biology standpoint, from biological standpoint, is one of those things that it's going to muddy the waters most of the time. However, when we do look at race and concussion assessment, we've had studies that look at specifically, again, neuropsych assessment, where they're not seeing differences between whites and African Americans at baseline neuropsych testing. However, when they start looking at post-injury, right? So at baseline, we're not seeing anything, but at post-injury, we are seeing differences when compared to whites on day 7. We're also seeing that at baseline, they're going to have lower, African Americans compared to their white counterparts are going to have lower speed indices as well as worse memory. We also, when it comes to presentation, African American children were more likely to develop concussion-related symptoms following sports-related concussion. And then when we look at recovery, there's really no relationship between SES and symptom duration or mispractice, according to Zuckerman. However, this was one of the key things, individuals with private insurance had more missed days of school than the public insurance. So basically, this is the first kind of breakdown of SES where they're looking at this private insurance as an SES mediator compared to their public insurance population. But we'll talk a little bit about that later. And then Agarwal said that they had shortened recovery in African American and Hispanic. So they actually had to combine their groups because they had a small sample of African American Hispanics. And so, but what they did find was that they returned 8 days sooner than their white counterparts. And again, we'll talk about that a little bit later. So I know I just sped through race, right? But there's your race talk, Steve. You're welcome. No, but many of these studies are gonna examine race without the qualification of SES. And I think that's where I'm gonna hit home today. Race does not equal socioeconomic status. So within our social determinants of health umbrella, we can see that there's race in SES, medical access, social factors, genetics, environmental and physical influences. But I think one of the biggest misconceptions is that when we're talking about SES, specifically low SES, we're talking about minorities. We're talking about this association with African Americans being in the low SES population. And so when you start seeing some of the research, when you look at race in isolation, one of the biggest issues there is that if they're not taking into account SES, you probably are going to see racial equity. You're going to see that regardless of who is in this sample, African American, white, Hispanic, whatever you're looking at, they're going to look the same if you don't look at SES in that standpoint. Because realistically, SES does not have a specific race, sex, culture, ethnicity. It's SES, and that's the great factor of SES. So when we look at SES, it is defined as someone's access to financial, social, cultural, and human capital resources. And I think that it's really important to say, a lot of times when you're seeing some of those, so I'm right now in Georgia, which is Southeast Georgia. I am in a very rural community. It is predominantly farmers, and they are predominantly Hispanic, Spanish-speaking farmers. And they might have lots of people in their household. And so when we're looking at SES, we do take financial security into account. However, it's the amount of resources that we are sharing amongst that family. So if I have I'll take myself, for example. If I am making, and I'm doing round numbers, if I'm making 50,000, but it's just me, then I am sharing 50,000 toward resources on myself. But if I have that same $50,000 income, but I have 8 children and a husband, then I am sharing that $50,000 amongst 10 people. And so that's how we're going to get this lower SES standpoint. And then that is typically mediated by parental education level. The more schooling a parent gets, typically you are going to find better socioeconomic status, their household family income, as well as typically we look at parental occupation too, right? Because if I'm a doctor, I'm probably going to make more than if I am an hourly worker at Target. However, I also want to make it very clear, we used to talk about it from a high, middle, and low class. And, you know, especially living in the days that we're living in right now, a lot of our middle class are very quickly shifting into this low SES standard because they don't have the money coming in as readily and as accessible as they did before. So SES is going to give you opportunities that may not have been afforded to other people that don't have this higher SES. So we do know when we look at the research in SES, they're going to be associated with cultural values, economic opportunities, and age, especially when we start looking at some of the neuropsychological testing. We also know that there are consistent differences between children living in households of low and high SES, particularly on scales of language and executive function. We know that parental resources may be challenging as we get to those lower SES. We just don't have the resources. You are going to have parents that have to make the decision of, do I let my child go by ambulance to the hospital if I can't put food on my table? Okay. And so because they had some of these limited resources, especially in our lower SES families, then they also don't typically have the reinforcement for desired behaviors. And they have a difficulty with scaffolding to encourage the development of executive skills. So that is my big general background. And now I'm going to go through a couple of studies that we've done. I've been fortunate enough to do in this population. And I'll joke, I've known Steve for a really long time, but when we were at Georgia, we did research and that was great. When I got to Ohio State, yes, I know, but when I got there, they were like, no, you're a clinician scientist. And it was the first time that I really had the opportunity to be like, well, what does that mean? And they were like, everything that you do from a research standpoint is based upon something that you're seeing clinically. And so this was actually a case that I had when I was at South Carolina. A 15-year-old football athlete reports to the physician for follow-up and clearance for return to participation. There was no baseline test available. Shocker, right? Because the one kid that gets a concussion doesn't have a baseline. After testing, the scores were significantly lower than the published norms on all composite scores. We then held him out, tested him again, held him out, tested him again, and his scores never returned to the normative values that we had established in this platform. So then we said, well, something must be wrong. So we did allow that athlete to go back and they returned very normally and it was great. But if we were waiting for their scores to normalize to what they should have been, this kid probably still would be out. And so it made me really question, well, what happened there? What is this issue that kind of came up? So we looked at a comparison between urban and industry provided normative values. So the great thing about it is I worked with the Columbus City Schools and we had a pretty good match sample to impacts norms. So we had 631 13 to 18-year-olds. We followed impacts norms. We divided them by 13 to 15 males, 16 to 18. And what we found was our kids on average were 10% lower on all variables. Across our 13 to 15, and then they were 10% lower except for visual motor composite score for our 16 to 18-year-olds. So again, I mean, I'm putting these up because I'm not going to talk about them in detail, but you can look at them later. But again, for every norm at every percentile, we're seeing significant differences. And so what did that mean? We know that there are, again, racial differences, But this is less about race and more about SES. This population was not 90% African American. This population was 50% African American in an urban setting. So when we start looking at this, we start saying, well, what did that really mean? So we know that we couldn't use impact norms for our population in Columbus City schools. So again, that's really important because that's not something that we've talked about. It's not something that we've really said, oh, well, if I don't have a baseline, what can I do if I can't compare them to them? So we ended up having to actually develop our own normative data set for impact within our population because we realized that we couldn't use their norms. Again, this isn't a push on impact, and this isn't saying that impact's not good. It's just, this is something that was missing for the population that we were working with. And had we never asked this question, we would have never thought through the idea of, oh, well, maybe we need to do something else. Okay. So still staying along with neuropsych tests and assessments, we did look at SES across neuropsych assessment. So this time what we did was within Columbus City, the great thing about it is we have very high SES and we have very low SES, and it is very polarizing. And so we were able to capture a sample that was large enough to really do some good information on. And again, what we found was there were statistically significant differences across all variables, with the higher SES group performing better and reporting fewer symptoms than the lower SES group. This is across males and females, this is across sports, this is across everything. And we're still seeing that there are significant differences across SES. And same thing, you can see here. Gonna go through these real quickly. So the one thing about this study that I want to mention, because I typically go through and I say, oh, well, you did the study on race or you did the study on SES, but did you really ask those big questions? And normally when I present things like this, people say, oh, well, your high SES probably had access to more medical care, or your high SES probably were smarter or were more thoughtful or something. And so what we did though was this was in one medical environment. And what I mean by that is the athletic trainers that served these schools were all from the same sports medicine clinic with the same training, the same, the same variables across the board. They had relatively similar backgrounds, educational backgrounds. They had relatively similar environments that they kind of came from, like what type of colleges and what type of schools they came from. They also had about the same amount of experience. So we're not talking about a novice athletic trainer compared to a very senior athletic trainer. And then we wanted to make sure that this was environmentally independent, meaning these kids were all from the same area. It's not like it's not like we took upstate New York versus Harlem. We really did. These kids were all in Columbus City schools or a variation of Columbus City. So they were in the same environment with the same access to medical care, and we still found differences. So you can't say that it's an environmental or medical access issue. This truly was an SES. So then we move on to concussion recovery. So same thing, high school athletic trainer hired through local hospital systems, covering 2 schools, one low, one high SES. It's interesting because this athletic trainer was a little younger. And during one of our staff meetings, she said, I just don't get it. I don't get why my kids are going to these doctors that don't belong in our health system, or why there's this lack of communication that they're going to the doctor and they're not telling me, or something's happening. And so we really started asking the question, well, what are the differences in these schools? Is it that they're accessing the resources a little bit better? Do they actually have more resources than the other schools do? And so we looked at identifying the incidence and recovery of concussion injuries in high and low SES athletes in the high schools. And then we also wanted to look at, again, the effect of SES on neuropsychological test scores, because this is a different population than what we'd used before. However, we wanted to make sure that we are getting very consistent findings. So we ended up with 596 athletes, 292 high and 304 low. The students were followed throughout the competitive season for incidents and time loss associated with injury. And when we realized we had 30 concussed athletes and 28 in our low, we were like, oh, that's awesome. Okay, so then we looked at the individuals. So our incidence, we had 10% in our high SES and 9.2% in our low, so relatively similar. So incidence did not seem to be affected by SES. But again, we saw statistically significant differences between verbal memory, visual motor speed, so our common areas. But this is the one I really want to hit on. When it came to recovery, what we found was self-report asymptomatic. Our high SES is at 10 days. Our low SES was at 3.6. The first time that they returned to learn, because for me, that was obviously important. I didn't just want to know when they were self-report asymptomatic and when they returned to play. I also wanted to know when they went back to school. And so, and this is full clearance, return to school, no accommodations. And so our high SES returned to school on average at 4 days, and our low SES returned to school after 1 day. And then our time loss, so time loss was defined as the amount of time that they were out until they could do full contact and or full return to sport. And our high SES was 17 days, and our low SES was 10. So, what does that mean? To me, this was eye-opening. This was like, oh my goodness. So our incidence was relatively identical. No big differences there. We're doing okay. Again, we confirmed that our high SES group performed better on our impact composite scores at baseline. So, okay, very consistent with the literature. However, if our high SES kids are performing better on the test, why are they taking longer to get back to asymptomatic, to school, and to return to play? Again, with an environmentally independent population, as well as identical access to medical care. But that's what's happening. So we do think this is consistent with the literature that actually just came out. And then we do think some of it's motivation. I know that there's a lot of talk in the literature about, oh, well, you know, the African-American kids are more motivated to go back because they need to make sure that they are actually playing sports and they have visibility so that they can go to these big time schools and get jobs and get all this other stuff and get out of the ghetto, right? But I actually think that it's less of that. I actually think that for us, this was a lot about overparenting. This is a lot about access to resources that are not within your current medical model. This is a lot about, and you'll see in the next study when we actually talk to the athletes about some of this stuff, they actually said, oh yeah, I went to the chiropractor. Well, last time I checked, and if there are chiropractors on this call, I appreciate you. But last time I checked, we're not typically sending a concussion to a chiropractor, but those are additional resources that would help and support the recovery process. Whereas our low SES group primarily stayed within the medical system, predominantly their athletic trainer in the school. So we also talked through this notion of, if we're talking about a low SES and this child is 13 or 14 years old, how many parents are comfortable with allowing their child to stay at home at 13 and 14 by themselves because they have a concussion? And guess what? If I'm low SES, I have to go to work to make money. And so we do think that that played a big role too. So we think that there are other things, but I think predominantly they're not biological, they're not genetic, they are environmental and they are social. And that'll be even more evident with the next study. So when we talk about managing concussions and community support in this group, we had a 17-year-old soccer athlete that had on-field loss of consciousness. So they were transported to the emergency room. They were treated for a neck injury. Yeah, they were treated for a neck injury and they stayed in the hospital for 3 days. When he was in the hospital, he was like, oh yeah, they were really concerned about my neck. So the first couple of days, they let me do whatever I wanted and I was doing great. And then they came back and said, oh, we think you have a concussion. And so then after 2 days in the hospital, they shut him down and they said, okay, no TV, no cell phone, we're gonna put you on the concussion protocol. And he got really upset with that. Like, that was the deal breaker for him. So then when he came back to school, He was really having trouble doing his work. He was having trouble returning to his normal activities. His grades began to fall. He stopped attending school. He had hobbies of computer coding and gaming. It's really funny because he told us that his mom took away his computers, right? His mom took away his computers and all of his batteries. And then he said, and I hid one and she found it. And then I couldn't play on my computer. So he was really upset about that. But this athlete really, he started sliding down that really scary path where he had some suicidal ideations because he didn't know what to do. And he said that a lot of it was because all of a sudden this concussion rocked his world. And so what we wanted to do was we wanted to look at this impact of adolescent concussion protocols across SES and gender. And we thought the best way to do this was really to kind of hear their own voice. And so this study is probably one of my favorites, and I shouldn't have favorites, but this probably is one of my favorites because we actually heard their voice, and it was amazing how honest and open they were with us. So we did 4 different focus groups of athletes aged 15 to 18. Within these focus groups, we did separate out our males and our females. We also separated out our high and our low SES males and females because we wanted to make sure that they could talk openly. And you know, when you get teenage girls and boys together, they tend not to want to say anything. And we were really worried about that. So we did semi-structured interviews. We did look at trustworthiness, and we triangulated across our participants as well as doing a peer audit. But a lot of the questions that we asked were just basic introductions. What sports did you play? What do you love most about your sport? What injuries did you sustain in sport? How did you feel when you had this concussion? How did you deal with missing practices? And so we really wanted to get at what happened. And so I pulled a couple of the more prominent findings. What do you love most about your sport? And the high SES boys, they said, oh, it's independence. And the high SES girls, they said stress management. And the low SES boys, they said it was the ability to be aggressive, and it was the brotherhood in their family environment. You know, so I love the quote, I can literally kill someone and not get in trouble with it. I mean, how many of us feel like that right now, right? We're all cooped up in the house. But this was one of those kind of telling stories. How did you feel when you were unable to practice due to a concussion? They all said that they felt frustration. And they had various reasons for the frustration that they felt. Some of them said they were frustrated because they didn't want somebody to tell them what to do. Some of them had frustration because communication was really poor. But one of the big things that came out of this is across both high and low SES, across males and females, they literally went through the phases of grief. Removing them from sport, they went through the grieving process. And I think that that's really important for us to understand and see, because as we deal with some of these athletes and some of these patients, when you take them away from what they have, you know, they don't necessarily always know what to do. And one of my favorite, boredom led to loneliness, and being lonely was bad. So as you can start seeing with some of these quotes are kind of telling of like, we were dealing with some athletes that really did start slipping down into that depression pathway. How did you manage these feelings? My favorite, the high SES, peers and left brain activities, right? Who says that? What 14-year-old girl says left brain activities? Okay, so we have very different ideas of how we're coping. But in our high SES boys, they went to mental health professionals. They slept. So they had really poor coping skills. And in our low SES boys, they did reach out to friends, and they reached out to this social support. But this quote, I took the injury bad, got angry and careless with life. I was salty, but I kept going until something could happen. This actually came from one of our low SES boys, but I don't know if anybody else would catch up on this. This is my poor little guy that had suicidal ideations. And somehow nobody caught it, and he managed to get himself out of that. So just again, understanding what happens and how each of our SES groups kind of react to it differently is going to be really important. Explain the frustrations. Everybody was frustrated about academics. And then the limitations we gave them. So that's not inconsistent. But what we realized was we developed this model of this idea of falling behind in academics. Can I? Yes. Okay. So they had this concussion, and most of the time we have this initiation of the intervention. And if we have effective communication, then we can kind of curb this teacher's expectations. But what we were seeing was we had ineffective communication. And then we also had inappropriate teacher expectations. So all of a sudden the kids are coming back to school and the teachers are saying, well, you have to make up all this work. And they're not prepared to do that. And so then all of a sudden we started seeing declining grades, and then the declining grades led to frustration. And so as healthcare providers, if we don't intervene in one of these steps, what we found was this cycle kind of repeated itself, and it just consistently got worse and worse and worse. And so once it got worse, we also realized that boredom is probably a mitigating factor of that, right? So the minute they get bored is the minute that bad things start happening. In our boys, we saw that after the injury, they experienced immature coping. So that was the sleep, that was the, they didn't quite know what to do. They played music, but then they got angry. And same thing here, if we don't intervene, it's going to get bad, and it's going to get really bad really quickly, okay? So in our low SES boys, what they did was they reached out to peer support. So they might have been angry, but they reached out and got peer support, and all of a sudden they were able to manage this. In our high SES boys, they got angry and they isolated. And so then the isolation just exacerbated the angry. And then all of that just kind of kept this cycle going. With our girls, we had very mature coping, and they did have some frustration, but for the most part, they were coping well, and their frustration was predominantly focused on the academic side. So our thing here was our participants were at least 6 months post-injury, 6 months, right? And so when we talk about recovery and we talk about returning to play and returning to learn, these athletes were 6 months post-injury, and we're sitting there interviewing them, and we are watching them exhibit these signs of inattentiveness and concentration issues. And we did actually have one of our kids get very angry. And so we don't think they actually had recovered from their concussion, even though they were 6 months out. But the participants were very clear. They want to get better. They want to feel better. They want to feel good about this. But the things that are really associated with these poor outcomes is boredom. The minute boredom pops in is the minute things start breaking down. And then there was very poor communication between the educators and the healthcare providers in regards to the restrictions and the reintegration plans. We talked about compliance requiring diligence from everybody, but one of the athletes said, honestly, don't just tell me what I can't do. Like, let's have a conversation about this. Because the minute you tell me what I can't do, I just want to tune you out. And then again, the poor parental over-involvement. One of our females, our high SES females, she didn't tell anybody that she had a concussion. And she didn't tell anybody, she fell and hit her head on a rock. And she didn't tell anybody that she got hurt. And so then she kept going, and the parents were like, oh, well, do you want to see your psychologist? We're okay. So we do want to worry about or think about that aspect, especially if there is medical care in the school system. So the easiest solution is to develop standard operating procedures for return to play and return to learn. We did realize that we had very vague return to play and return to learn. And so making sure that we actually met with the teachers and understood, because the teachers are in the school system, and what they were thinking was, well, the athletic trainers are only here in the afternoons. They're not here during the day when some of these problems come up. And the athletic trainers are like, well, that's great that you want to help them, but that doesn't help them return to sports. So how does that work? So making sure that we're incorporating these clinical interventions to also look at the psychological aspect is going to be really important. Again, especially when you're looking at the differences between your high and your low SES populations. And then we want to make sure that we enhance communication, emphasize to your parents in preseason meetings to go to the AT, because the AT can be that line of communication between all of the other healthcare providers. You can still go to the chiropractor. You can still go to the orthopedist. You can still go to whoever you want to go to. But if the AT is kind of in the loop there, or you have one centralized person that's kind of managing some of that care, it's going to really be helpful in the long run to make sure that this process is seamless, or as seamless as possible. So, for this study, our clinical bottom line, low SES performs worse on neurocognitive tests. We need to establish age and SES appropriate norms. High SES takes longer to return to play and learn. Again, making sure that we're looking at that interprofessional communication for that smooth transition of care. We definitely want to look at the psychological needs. The low SES typically want additional support. The high SES want to be isolated and have poor coping skills. So you as a clinician might need to dig a little bit harder into that high SES group to make sure that they are not isolating, because that's a very poor coping skill and they're going to have poor outcomes. So that is kind of the end of my research area and the end of my research talk. And so I wanted to leave you with some clinical pearls, and I really wanted to give you an opportunity to kind of ask questions too. So we know that evidence exists to support that racial and more consistently SES differences exist in concussion assessment and management. So I often get, well, what can I do? I'm just a researcher, or I'm just a clinician, or I'm just this person. So what can I do to help? And so I've come up with, ask these questions. First question, and again, it kind of fits for throughout this pandemic too. How are you doing? I can't tell you how many people have stopped and said, Tamerah, there's a lot of stuff going on. How you doing? Now, that can also be a loaded question, because if I'm in that mode where I'm like, blah, 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 right? Like all of a sudden, I'm just gonna unload on you. But most of the time at the younger phases and in our athletes, they're not just gonna totally unload on you. But if they do, that's okay too. It is okay. Listen to them, because they might be telling you something that you definitely need to know. This gives you an opportunity to determine your other symptoms and needs that may mimic concussion-related issues. What about their home environment? They may actually allude to what's going on at home. Maybe they are not following your rules and your regulations and your guidelines to return to play, because you're telling them that they need to go home after school. But then when they're at home, they're in a house full of people making lots of noise, and the noise is really irritating some of their symptoms. So understanding what that home environment looks like is going to be incredibly helpful. Food insecurity. We check symptom scales, right? And headache is typically our #1 symptom. But what if it's a hunger headache? Did you ask them, have they eaten today? Did you ask them? We have at Georgia Southern, it breaks my heart, but we have a lot of our students, or not a lot, but we have students that are homeless. And so if you're sitting up here telling me that we're in 90-degree days and you're sleeping in your car, that might actually influence how you're recovering from concussion. And then if you ask that, you might actually find that you have a little shared experience, and that'll give you a little street cred. And what I mean by street cred is, like, if somebody says, oh, well, you don't look like me. It broke my heart the one time that one of my students, athletes, was like, you're old. And I was like, I'm not old. What are you talking about? But he was like, you can't relate to what's going on in my life. You're old. And I was like, wow, okay. So then I had to connect with him on a very different level. And we found out that we were both really big foodies. And so, like, every day I'd come in and be like, hey, did you go to that new restaurant? And we could talk about it. And it gave me a little bit more credibility with him, that all of a sudden I could talk through some of the things, and he shared that experience. And so then that gave us a tighter bond where we could actually grow and develop a little bit more in his recovery and his rehab. Okay. The second question, and this is a tough one. What do I think or believe about this population that may change how I assess, treat, and manage them? Okay, you gotta think about your biases. You gotta think about your privilege. You gotta think about some misconceptions you have. And I'll take it back. There's research out there that in the 1940s, they used to teach nursing students that if they had an encounter with an African-American person, they had to inject the needle harder because their skin was thicker. Okay, so those misconceptions are out there, and we're not sitting up here calling somebody racist or anything like that. It's just understanding what biases you come into that treatment room with. Like, I can tell you right now, like, we are the stereotypical African-American family. When my family comes over, we are loud, we can be obnoxious, we can do all of those things. And so, you know, I started this talk with saying, I talk really, really fast, and I tend to talk really, really loud. So if I go in to a patient and I see that they may look like me, am I going to assume that they're going to talk really fast and they're going to talk really loud? And so all of a sudden, if they're talking very quietly, am I like, oh, is something wrong with them? So understanding your biases, understanding the differences that you have between you and the population, and then ask yourself the question, and this is a hard one, do they trust me? Because if they don't trust you as a clinician, they're not going to disclose. They're not going to share this information. They're not going to you're not going to be able to do the job that you really want to do and need to do with them, because they're not going to open up to you. And there's a lot of literature out there on same culture, same sex clinician patient, right? And it's for that very reason, because you have to have and be able to experience some type of shared reality so that somebody feels comfortable enough to actually open up to you. And that's not going to happen post-concussion if this is the first time you've seen this athlete, unless you ask some of these questions. How can I effectively communicate with this population in this community? Do I provide clear instructions and pathways of communication between all parties involved? So I grew up in a military family. My dad is retired Air Force right now. And so I would say that we grew up very affluent, middle class, African-American family. And so my parents and we all went to physicians on the military installations. And so your physicians would come and go pretty regularly. And so you may not have the same person, but I went to an appointment with my mother recently, and I kid you not, the doctor walked in, he asked her all his questions and he was great. And he never put his hands on her. And so again, remember, communication, more than half of your communication is nonverbal. So if you're saying, oh, because my mom left and she was like, why didn't he actually look at my arm and touch me? Because that's what I was complaining about. And so that kind of made her start thinking, well, why didn't he, would he have done that with somebody else? Or is it because I'm overweight? Or is it because, you know, he was more concerned about my diabetes? And so making sure that you have this good line of communication between you and your patient is going to really help. With concussion, one of the things that so in that study with the qualitative research, we asked, what can we do to make this better and manage concussions better? And one of the athletes said, you tell us to rest and you tell us not to text and you tell us all this stuff we can't do. And then you give us instructions on paper and you ask us to read it. That seems kind of silly, doesn't it? And at that moment, we were like, oh, it kind of does. So making sure that those clear instructions and pathways, they can actually get to and understand and be very easily used. Do they think I care about them and their well-being? I typically use a quote with my students: people don't care how much you know until they know how much you care. And in this population, there is a lot of mistrust in the medical community. There is a lot of anger and there is a lot of disappointment, especially if you don't look like me. And that can be incredibly frustrating for the clinician. It can also be incredibly frustrating for the patient. And so understanding what can you do to really talk through, how do I let them know that I care about their well-being? I go in and I do research. And for a really long time, I was known as the concussion lady. Hey, it's the concussion lady. But knowing my population, I also knew that a lot of them were food insecure. So they also knew that I walked in with food. And so, and the rule was, if I have it, you are more than welcome. I would put it in a drawer in the office and they were always welcome to go in. They never had to ask. They never had to say why they wanted it. They could just go in and grab food because I had a lot of food insecure. And so it was building those trust values, building that to say, no, I care about you. Like, yeah, I need your data. Don't get me wrong. I really need this data and we're going to do this research. But what am I doing to show you that I care about you and the information I'm getting from you? And I value that and I value you. It's going to go a long way. And then, do I know who their advocates are? And I think this is probably really important, especially if you're working in the school systems. And not only who their advocates are, but who their adversaries are. If you know that you have one teacher, maybe it's a PE teacher, or maybe it's a counselor or whatever, that just totally writes some of these kids off just because of who they are or what they do, then understanding, like, maybe that's not the point of contact that I want to use to make sure I'm communicating with their other teachers. So understanding who their advocates are. And guess what? You can be that advocate, right? So being willing to be an advocate is really helpful in this population. All right, my last couple. So we know that low SES, specifically minority athletes, are using sports as an anger management tool and a support system. So we found that out with our qualitative study. When we remove them from sport because of a concussion, right, the standard management care, what are we doing to replace the anger management strategy? And in some areas, especially if you're dealing in a population that has, like we had an unfortunate problem with gangs in Columbus City. And so the gangs would leave the athletes alone. It was a protective mechanism. And so the minute they stopped participating in athletics, the gangs could kind of go and say, oh, okay, well, come join us. We'll take care of you. And so that's when we realized we can't just pull them out of sport and say, okay, just go home and come back in a couple of days when you feel better. We needed to make sure that we had something that kind of kept them in our niche, right? And so what can you do to help them with their anger management strategy? Some of that is just, again, asking the question, how are you doing today? And giving them an opportunity to talk about it. Some of it might be more substantial and they might need a counselor. They might need additional services that you can't provide. And then what kind of support system do I do if I remove them from the sport? Because they are very heavily relying on each other to support them through this process. So we've talked about doing things like peer mentors. Again, I can't go in there and be like, oh, I feel what you're talking about when I'm looking at them and they're crying because their girlfriend didn't call them back or didn't text or didn't respond to their TikTok. You know, I don't have a sense for that. But if I can find somebody that has that shared reality with them that understands, dude, that's devastating that she didn't DM you, you know, like, I'm just like, huh, what? Okay. You know, my 9-year-old nephew had to teach me how to floss and understand, like, oh, flossing versus dapping, right? And so making sure that you give them the support system that they need. Maybe they can't be out on the field. Maybe they can't be in the gym. But what support system can we give them that will help mimic that so that they can recover a little bit faster and better? All right, last one, and this is probably the easiest one. Let's ask our test manufacturers and our researchers to provide SES appropriate normative data. Because again, the kid that needs it the most is almost always going to be the kid that misses baseline testing, right? And so if this is something that's as simple as, hey, when you're doing your test development or when you're developing your quartiles, tell me what your numbers look like so that I can compare apples to apples instead of high to low SES. All right, so in conclusion, we have to acknowledge differences in SES race during our concussion assessment, management, and recovery. As healthcare providers, we want to be aware and adjust for the population in which we are working and utilize the most appropriate assessment tools for that respective population. And this does include bedside manner. So with that, my references. I do it for these two little guys, but who do you do it for? So at this point, I will stop talking finally and take whatever questions you have. Thank you for your time.
Great, thanks, Tamerah. Very informative talk, very enlightening. Appreciate you coming and talking and just being direct with it. I think that's what we need right now. So I'm gonna ask Sandra to go ahead and stop the recording, and then we will